Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Hi, everybody. Treatment updates from CROI. And some of you may have already seen this AIDS clinical conference, but we will review that content, at least one less abstract, and slow things down a little bit so that we can talk a little bit more about how it might change practice based on what we've learned. So I have no disclosures. We will first spend actually most of the time talking about rilpivirine updates for the long-acting injectable, and then just one or two updates about lenacapavir. And moving on, so as background, I know that we all probably know these data, but that Atlas FLAIR and Atlas 2M studies, we know demonstrated efficacy of long-acting cabril and led to FDA approval for those with viral suppression. And that in at least the Atlas 2M study, we have information that virologic failures have occurred at a rate of 2.3% every 8 weeks versus 0.4% every 4 weeks. And unfortunately, clinical trials to date had not included persons with adherence challenges. Kind of similarly, clinical trials to date had very little representation from Africa. I looked up in Atlas and FLAIR the number of sites that were in Africa, and out of 120 sites, for each Atlas and FLAIR, there were about 7 and 8, all from South Africa. So not much representation from the continent, and a little representation amongst people from Africa, as I've mentioned, where evidently the vast majority of people that have HIV are Black African women, have different subtypes of HIV-1 than we were used to seeing here, at least in the United States, have a high history of exposure to NNRTIs and pre-treatment resistance, and have varied treatment strategies with infrequent lab monitoring. In my experiences in Kenya, granted a while ago, it would sometimes take months to get a viral load back, on the order of 2 to 3 months. And so as a result, what do we do in those scenarios? So we will talk about the CARE study, which occurred in sub-Saharan Africa. We'll review Latitude interim data, and then talk about real-world experiences from Ward 86 with their prior study, which we learned about at CROI last year, and then some virologic failures from a poster at a Chicago clinic. And I just learned that some people find real world to be offensive, that perhaps clinical trials, sort of suggesting that clinical trials aren't real world, but it is certainly a more artificial environment than a non-clinical trial environment. So let's talk about CARES. So CARES was a phase 3B randomized open-label active controlled non-inferiority study of individuals who are adults who were stable on oral TDF plus XTC, so either 3TC or FTC, plus dolutegravir, nevirapine, or efavirenz. Their viral loads must have been suppressed for at least 4 to 12 months prior to and at screening, and no history of renal failure, and no hepatitis B surface antigen positivity. Okay, that makes sense. The person could not have active hep B, but they interestingly also excluded individuals with isolated core antibody positivity. They then randomized those, around 500 individuals to the oral standard of care versus rilpivirine injectable every 8 weeks with an optional 4-week oral lead-in. This part I find very interesting and also nerve-wracking, that a viral load was checked every 24 weeks. So that's every 6 months. And that resistance analysis was performed at 48 weeks due to what they referred to as their public health approach, just based on WHO recommendations. And then, so as a result, proviral DNA was performed for archived resistance on stored PBMCs after the fact. So none of that resistance data was obtained prior to randomization. It was all after the fact. So going into things a little bit blind, if you will. These are some of the baseline characteristics from the study, and I'd like to draw your attention to the red rectangle on the right, where you can see that first off, the groups were well matched, but there were 58% of who were female sex, that the BMI was mostly low, that were only 21% of individuals had a BMI greater than 30, that the median time on first-line ART was 8 years, so a relatively treatment-experienced group, with 75% of whom had prior exposure to NNRTIs, and 92% were on an INSTI-based regimen at screening, and the presenter stated that most of those individuals were on TLD or TDF, lamivudine, and dolutegravir. And then as you can see here, again, after the fact, they went and got archived DNA analysis, found that 56% of individuals had a viral subtype A1, that 13% of individuals had rilpivirine-associated mutations, and that 16% had CAB-associated mutations. So this is a large amount. And as you might wonder, Jehan, why are you pointing out that the viral subtype was A1, et cetera? There is a prior study by an author named Cottrell that looked at specific risk factors for virologic failure on CAB rilpivirine, and they found that having a viral subtype A1/A6, having a BMI greater than 30, and having rilpivirine-associated resistance at baseline was associated with failure. So as a result, I wanted to sort of highlight those, and I believe that's why they highlighted them as well. These were their results, that long-acting Cabril demonstrated non-inferior virologic efficacy as compared to oral standard of care. And you can see in the rectangle again that blue is the Cabril and that gray is the oral standard of care achieving viral suppression. 73% of individuals had an injection site reaction, that satisfaction increased for those who switched to long-acting Cabril, and that 96% of scheduled injections occurred within the 7-day target injection date. So that is, I think, pretty high. And there were 2 cases of virologic failure in the injectable arm, none in the standard of care arm. In this next slide, I'm going to share patient characteristics of those 2 failures, one of which was confirmed on repeat. The second one, they couldn't confirm it because the patient died of non-HIV related things. And so as you can see here, what their viral load was at the time of failure, that neither of these individuals had any delayed injections. They both had a low BMI. One had subtype A1, the other had subtype D. And at least for the patient on the left, you can see that at baseline had no NNRTI or INSTI-RAMs, but then at failure failed with significant new resistance with regards to both NNRTIs and INSTIs. However, were able, interestingly, to resuppress on TDF3TC, dolutegravir, TLD. And then patient 2 had, again, they found out after the fact that the person had an archived K103N and an E138A, and then at failure still had that resistance, but accrued another V106A and an G118R. And so the conclusion from the CARE study was that at week 48, long-acting Cabril every 8 weeks administered in sub-Saharan Africa in a public health setting with, again, viral loads checked every 6 months, was non-inferior in virologic efficacy to an oral standard of care, had a good safety profile, and was well tolerated, that there were only 2 cases of virologic failure that occurred in the long-acting Cabril arm, both with emergence of INSTI and NNRTI resistance, and that in demonstrating this, that the CARE's 48-week results are a key first step in implementation in this patient population. So I think my takeaways from this, for as far as, how will this change my practice, it really makes me wonder, here is a cohort of individuals who were getting checked less frequently than we are checking that had a lot of baseline resistance, and maybe they do okay. I think what I would like to see is the 96-week data. And so I am eagerly awaiting, I'm always eagerly awaiting CROI, but I'm also awaiting 2024 results to see what happens with CARES. I am not going to start checking viral loads less frequently or feeling confident about putting people on Cabril with CAB or rilpivirine associated mutations at this moment, but maybe I'm thinking, maybe in the future, this might actually change my practice. But it certainly piques my interest and makes me think, maybe I don't need to stress or worry as much. So that's CARES. Next is the Latitude study, which was a phase 3 prospective randomized open label trial of people with HIV who have barriers to adherence, which they defined as poor viral response despite oral ART for at least 6 months, or loss to follow-up with ART non-adherence for those prior 6 months. They could not have hepatitis B, and they could not have INSTI or rilpivirine associated resistance historically or by screening. And as you can see here, they had this I think complex study design of multiple steps. And it's step 1, they had to be placed on an oral standard of care and ideally achieve viral suppression. And they were given conditional economic incentives. After they attained viral suppression, then they were randomized to step 2, which is where we are, which was arm A, cab-ril, every 4 weeks, and arm B, a standard of care. Then their plan had been to sort of then go everybody onto cab-ril every 4 weeks and go from there. And their primary outcome was regimen failure, defined as the earliest occurrence of confirmed virologic failure or treatment discontinuation in step 2. These are their baseline characteristics of individuals in latitude from Adia Rana's oral abstract. And she had made in red some things that she found to be important, which were there were 20% of individuals who were young, 30% of individuals who were female, 5% were on the transgender spectrum, 64% of whom were Black, 17% of whom were Hispanic, and 14% of whom had a prior history of IV drug use. In the group, only 14% of individuals had a viral load greater than 100,000. The baseline CD4 count was a median of 270. And then, as I had mentioned, that in step 1, people were placed on oral regimens, given conditional economic incentives, and meant to achieve viral suppression before being randomized to either continued oral or IM cab-ril. And you can see here in this first row that unfortunately 17% of people in the cab-ril arm actually happened to have a viral load that was greater than 200 at that time, and in the standard of care, 7. And so including 8 participants with a viral load greater than 10,000. So they were still randomized, and I remain curious as to what happened to those individuals. But that was, again, that was not meant to be the case. It was ideally meant to be for individuals who were virally suppressed, but the vast majority of them were. And then we got interim data where you can see on the left, they had the regimen failure data where standard of care was in blue and the cab-ril was in red. And there were 28 people who failed in the cab-ril arm, 6 had virologic failure. And then they looked at the secondary outcomes of virologic failure, treatment-related failure, and permanent treatment discontinuation. And the authors kind of highlighted in red that the virologic failure and the treatment-related failure arms were statistically significant and better for rilpivirine for virologic failure and treatment-related failure. And I don't think that this is surprising for most of us. I think a lot of us had thought if someone has a hard time taking a pill, giving them an injection will be better. But we didn't know, and we still don't know what the long-term results of that will be. However, as a result, based on these secondary outcomes, the Drug Safety Monitoring Board changed the study and had it so that individuals will all be on rilpivirine. They also found that injection site reactions occurred in 57% of individuals, that 93% of people received their shots on time, and that of those with confirmed virologic failures, again, 6 in the cab-ril arm, 28 in the standard of care arm, 2 people with cab-ril had development of resistance, and I have highlighted here the resistance that they had, which was both NNRTI and INSTI resistance. So thus, in persons with HIV with adherence challenges, cab-ril Q4 weeks showed superior efficacy to oral standard of care and secondary outcomes, and there were fewer virologic failures and fewer treatment-related failures. As I mentioned, given these key secondary endpoints, the DSMB halted randomization and offered everybody cab-ril every 4 weeks, and thus the data supports the use of this in populations with adherence challenges. What am I going to do differently about this? I think you all might recall after the CROI 2022 update that after getting the long-acting cab-ril data, I had said, I am going to be more stringent about people who are virally suppressed, doing great on their oral regimens, and wanting to go on rilpivirine, because there are some failures that we just don't understand. And if something's working orally, why potentially risk it while we're getting this data? But that for individuals who have a very hard time taking pills, that I was willing to be more lenient and get people on cab-ril. And we've been trying to do that. Again, it's very difficult, at least working in our big UW system, to get systems-wide change. And then now seeing Latitude, I read these results or saw these results and thought, yes, that makes sense. 2, this is great. 3, whoa, this is gonna be a lot of work because it means that I think we need to start implementing rilpivirine in people who are having a hard time with adherence. And I think that that subset of individuals that we are having a hard time getting suppressed, I think that maybe this is a way that we can do it. And I still look forward to long-term results. So that's that. Now for the lightning round of reviews for the remaining abstracts. The Ward 86 rilpivirine data, week 48 results, as you might recall last year, that they shared that 55 out of 57 individuals of theirs who were placed on rilpivirine without virologic suppression achieved viral suppression at a median of 33 days. And at that time, they had a virologic failure rate of 1.5%. And then now they gave us 48-week data. And they have 286 patients on long-acting cabril. 101 of them are viremic, or at least have a viral load greater than 50. And then 59 were included in this week 48 analysis, and that 81% remained on rilpivirine and were virally suppressed. And 93% of them achieved viral suppression on long-acting cabril plus another agent. So kind of using cabril plus something else. And 3 individuals had virologic failure for a VF or virologic failure rate of 5%. 2 occurred within 8 weeks of initiation despite on-time injections. These were the same 2 people that they described at CROI 2023, the patient 1 and patient 2. And then 1 was following self-discontinuation of ART. That was new in the past year. 2 were lost to follow-up, and there was 1 individual who did not achieve viral suppression at all by, I believe it was week 8. Their viral load was still in the 400s, so they added lenacapavir, and that individual still has a viral load of about 118, but less than 200. So this was their week 48 result. And then there was a poster from Rush in Chicago of a clinic of individuals who had 75 individuals who were virally suppressed, who were switched to rilpivirine. 10 of those individuals received them at an independent infusion center. The 65 of them received it at their clinic. And there were 3 virologic failures that occurred, again, a rate of 4%, 2 at the infusion center, 1 at the clinic. The virologic failure occurred at 8, 10, and 16 months, so pretty far into therapy. All of these individuals had used a 1.5-inch needle, and then all 3 switched to a PI-based regimen and achieved viral suppression. And this is a picture of their table where they talk about these patient characteristics. I think things I would like to highlight is that they're all, again, BMI was 27. This person's BMI was 35 and, was still using a 1.5-inch needle. And then this patient had a BMI of 28. Patient number 1 had perinatal acquisition of HIV, and so has had HIV their entire life, so thus had had lots of ART exposure. Notably, they had had prior rilpivirine exposure, though the only mutation they previously had was an M184V, and then when they failed, they had accrued all of these mutations. So this was worrisome because, again, these were all on time. I don't think I actually wrote that in one of the bullets, but was a concerning bit of data to see that, again, people that we think don't have resistance, at least in patient 2 or 3, and even in patient 2, in Atlas and Flare, K103Ns were allowed into the study, but then patient 1 is a little bit different, but nonetheless failed with accrual of a lot of new mutations. And then for lenacapavir updates, as background, lenacapavir is a capsid inhibitor administered subcutaneously every 6 months that was FDA approved in 2022 for multi-drug resistant HIV, which was informed by the Capella study, which was where when lenacapavir was combined with an optimized background regimen in individuals with MDR HIV, len every 6 months led to viral suppression at week 104 in 82% of people with HIV by their missing equals excluded analysis. And as you can tell, I am focusing on long-acting medications, and which is why I wanted to talk about lenacapavir ever so briefly. And so only 2 abstracts do I want to share about. One is another study that came out of Ward 86, the UCSD Owen Clinic, Metro Health's HIV Clinic, and UPenn, case series of 34 patients from these 4 clinics who were using off-label lenacapavir and cab with or without rilpivirine. So they either tossed the rilpivirine or didn't toss the rilpivirine for selected patients who are having adherence challenges in hopes to have someone be on a long-acting only regimen in individuals who perhaps may not have been rilpivirine candidates otherwise. The patient characteristics are as follows: mostly male, 41% Black, 38% Latino or Latina, 79% and 71% received cab every 4 or 8 weeks respectively. And then here that most people used len plus cab because of NNRTI resistance or INSTI-RAMS, high viral load, or continued viremia on rilpivirine alone. And they have a table from their poster, and this will also become a paper to be published soon, where they go through every single patient. So if you are thinking about making this regimen a reality, I would definitely recommend looking at their table because it has a lot of data about each patient. And they found that 44% of individuals had an injection site reaction and 94% of them had viral suppression. That occurred at a median Q8 weeks after starting lenacapavir. And that's up from a baseline viral suppression rate in this group of individuals of 47%. Last, weekly oral islatravir and lenacapavir. Phase 2 trial of once weekly oral islatravir, an NRTTI, plus oral lenacapavir compared to BIC/TAF FTC in people with HIV who are virologically suppressed. 94% of individuals achieved viral suppression. It was well tolerated. As you might recall, previously, islatravir was associated with drops in CD4 cell count and absolute lymphocyte count, which were quite dose related. Now they have adjusted that, and this would be a once weekly oral only regimen. There was also another presentation about I believe a once weekly INSTI as well. So again, we are, I think, just going to see with each conference more and more data about long-acting regimens beyond just cabotegravir and rilpivirine. And so I wanted to alert you that is out there. So in conclusion, CARE's data demonstrated that long-acting Cabril was non-inferior to oral standard of care in sub-Saharan Africa, that Cabril is superior to oral standard of care in key secondary outcomes in the Latitude study, which looked at people who had adherence difficulties and led the DSMB to stop randomization and offer Q4-week Cabril to all eligible participants, that long-acting Cabril appears durable, but real-world virologic failures are occurring more in the 4 to 5% range. And some of those studies, like the Ward 86 one, was in a cohort of individuals who were not virally suppressed, right? But in the Rush Chicago abstract, those individuals were virologically suppressed. So I still think that the virologic failure rate is a little bit closer to 5% as opposed to the like 0.4% that we saw in clinical trials, which are perhaps artificial. The combination of len plus long-acting cab plus minus long-acting rilpivirine proved efficacious in 34 patients, and we'll likely see more data about this in the coming years. And that's still in phase 2 trials. Weekly oral islatravir and len has the potential to become a long-acting option for persons with HIV, as are, I think, a couple of other things that are in the pipeline. So that is my CROI treatment updates.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.